A true case of aortic pseudostenosis has been described following Bendal procedure, which is combined replacement of aortic valve and ascending aorta with a graft. A person presenting with dizziness and collapse after the procedure was found to have pseudoaneurysm formation at the anastomotic site, causing aortic pseudostenosis. But a more common situation is pseudo-aortic stenosis in persons without left ventricular contractile reserve. That is a variety of low flow, low gradient aortic stenosis in which aortic valve opening is reduced because of left ventricular dysfunction. Even moderate aortic stenosis appears as severe aortic stenosis. In a healthy heart, the force of blood flow, that is transvalvular flow, is high enough to open the valve to its maximum anatomical potential. In pseudostenosis, low cardiac output is present, the pump is failing with left ventricular ejection fraction less than 40%. Incomplete opening. The flow is too weak to overcome the inertia of the aortic valve leaflets. To differentiate, a low-dose dobutamine stress echo is performed to increase the heart's contractility and flow rate. In true severe aortic stenosis, as the stroke volume increases, the pressure gradient rises significantly, but aortic valve area remains less than or equal to 1 square centimeter. This indicates a fixed mechanical obstruction. In pseudostenosis, as the stroke volume increases, the force pushes the leaflets wider. The aortic valve area increases to more than 1 square centimeter and the gradient remains relatively low. Absence of contractile reserve. If the stroke volume fails to increase by at least 20%, the test is inconclusive and a CT scan for assessing calcification of aortic valve is often the next step to look at the physical burden of calcium on the valve. Here is a comparison. Aortic valve leaflets are heavily calcified and immobile in true severe aortic stenosis very often. In pseudostenosis, they have mild or moderate calcification. Response to stress, area remains small, less than 1 square centimeter in true severe aortic stenosis, while in pseudostenosis the area increases to more than 1 square centimeter. Prognosis, true severe aortic stenosis benefits from transcatheter or surgical aortic valve replacement. On the other hand, pseudostenosis is managed medically with heart failure therapy. Distinguishing these is critical because true aortic stenosis requires surgical or transcatheter aortic valve replacement. Pseudostenosis is primarily a failure of the left ventricle. Replacing the valve in pseudostenosis generally does not improve the patient's symptom or survival, as the valve was never the primary bottleneck.